first malignant tumor that we are going to talk about is based on the chondrocytes, right? This is your chondrosarcoma. Now we already know a lot of things about this. What is it? We know that it occurs in older population, somewhere between 40 to 60 years of age. We know that this is a metaphyseal tumor. We know that it's a malignant tumor. We know that it's a cartilaginous tumor. So it will be lucent with calcification here and there. And what kind of calcification will you see? If you remember, in cartilaginous tumors like chondromas and chondrosarcomas, what type of calcification will you see? Popcorn calcification, ring or arc calcification, or O-ring sign, right? That is what it is. It is a metaphyseal tumor occurring between 40 to 50 years of age. It's a calcified tumor in the pelvis and the proximal femur. Okay, so there's a slight controversy which is more common location since both of them are close to each other. This is the pelvis and this is the proximal femur, right? So this is the location and you can clearly see that this is the lesion that gives you your popcorn or ring arc calcification. It is both chemo and radio resistant. The treatment is surgery. That is what you need to know. One very important MCQ that you need to know about is that chondrosarcoma has a paraneoplastic syndrome where the patients usually, because of that paraneoplastic syndrome, present to you with hyperglycemia. Okay, that is all you need to know about chondrosarcoma. Now moving on to the next malignant tumor, that is osteoblastic malignant tumor, that is osteosarcoma. What do we already know about osteosarcoma? We know that it occurs in the metaphyses. We know that it's a bimodal tumor that occurs in primary fashion, that is between 10 to 20 years of age group, and secondary fashion, that is between 40 to 60 years of age group. Primary is more common than secondary, right? It is the most common malignant bone tumor in children, right? Secondary causes are the one we read already, Paget's disease, right? Patients with Paget's disease have increased risk of osteosarcoma later in life. What else do we know? We know that it gives you your sunrays, sunburst, and Codman's triangle appearance as periosteal reactions. What else do we need to know about this? How will it be on X-ray? Because it's osteoblastic, there will be abnormal osteoid, and so it will be dense or sclerosed on X-ray, right? We know so much about it already. So let's see. It is the most common bone tumor in children. Most common bone tumor in children occurring in the second decade, that is primary osteosarcoma. Secondary osteosarcoma occurs in 40 to 60 years of population, and the most common cause is Paget's disease. Other causes that you can remember is fibrous dysplasia or exposure to radiation. This is important. If you are exposed to radiation, the chances of you acquiring osteosarcoma later in life is very high. In fact, it is the most common radiation-induced bone tumor. It is the most common radiation-induced bone tumor. Please remember not to be confused with what is the most common radiation-induced tumor. You see, the most common radiation-induced tumors are hematological or blood tumors. Bone tumor is osteosarcoma. Like I said, primary will be much more common than secondary. Location is metaphyseal. It is the most radio-resistant tumor. So radiotherapy usually doesn't respond or work for osteosarcoma. Abnormal osteoid will be formed in the patients. Now, most of the patients who present to you with osteosarcoma already present to you with metastasis. By the time they present to you with osteosarcoma, already have micrometastasis. And these micrometastasis most commonly goes to which part of the body? Lungs. So how can they sometimes present to you? Instead of presenting to you with a bony problem, they present to you with lung problems like pneumothorax. Now I quickly recall the radiological findings that I told you would see in osteosarcoma: sunrise, sunburst appearance, and Codman's triangle. What did I tell you? The lesion will grow in the metaphysis, and as the lesion grows, the periosteum is lifted with it. And what is the function of the periosteum? To give you periosteal reaction. So bone will form under the periosteum that is elevated in the shape of a triangle. This is known as Codman's triangle first. Second thing, the bone will grow, the tumor will grow, and if you recall from the basics, the periosteum is anchored to the bone with the help of fibers known as Sharpey's fibers, right? Go to the basics and review that. So Sharpey's fibers basically anchor the periosteum to the bone. So in osteosarcoma, there will be calcification or ossification of these Sharpey's fibers, giving you sunray or sunburst appearance as a periosteal reaction. This is a pathological specimen of osteosarcoma. You can clearly see that the lesion is in the metaphysis, and you can clearly see that it is growing in a sunray sunburst fashion, and the periosteum is elevated. So the bone starts to form under it in the shape of a triangle. This is your osteosarcoma. Same thing here. Lesion is growing, periosteum is lifted off, and there is triangular periosteal reaction in the shape of a Codman's triangle. Now, there are various types of osteosarcoma. The most common is the classical or the intramedullary osteosarcoma that we just showed you. The other variants are periosteal, perosteal, and telangiectatic type. These are just some things that you should know. The treatment is important because I've told you it is the most radio-resistant tumor known to man, number one. And number two is by the time they present to you, they already have micrometastasis to lungs. So you should start systemic therapy before you go for the local therapy. So what kind of systemic therapy can you give? You cannot give radiotherapy, right? Because it's radio-resistant. So you will offer chemotherapy. And giving chemotherapy before surgery is known as neoadjuvant chemotherapy. Then you can go for a wide excision if possible, or limb ablation if not possible, that is surgery. And after surgery, you will go for chemotherapy again in order to control the chances of recurrence. And if you give chemotherapy again after surgery, you call it adjuvant chemotherapy. So chemotherapy before surgery, neoadjuvant therapy, surgery in the form of either wide excision or limb ablation, and then chemotherapy once again after surgery in order to prevent the recurrence. So this is the total treatment of osteosarcoma. Sometimes they ask you what chemotherapeutic agents you use in osteosarcoma. The agents are the agents of T10 protocol, and the most important drug of this protocol is basically methotrexate, and that is all you need to remember about osteosarcoma. Now moving on to Ewing sarcoma. What do we already know about Ewing sarcoma? We know that it's a miscellaneous tumor. It is a malignant tumor seen in children, right, in the first, second and third decade. Most common malignant bone tumor of the first decade. The most common malignant bone tumor of the first decade is Ewing sarcoma, but Ewing sarcoma most commonly occurs in the second decade, right? So it's the most common tumor of the first decade, but Ewing sarcoma most commonly occurs in the second decade, right? It's femur and it is diaphyseal, and now it is slightly more common in males than females, whereas giant cell tumor was more common in females than males. Now please remember that Ewing sarcomas are all sarcomas, and since sarcomas are always high grade, there is no such thing as a low-grade Ewing sarcoma or high-grade Ewing sarcoma, which you might get confused about. All Ewing sarcomas are high-grade Ewing sarcomas. First point. The second point is that there are certain poor prognostic factors of Ewing sarcoma. If they are associated with the patient of Ewing sarcoma, his prognosis becomes poor, and they ask you on the exam. So what are the poor prognostic factors? Patient coming to you with metastasis, a large size of the lesion, patient with fever and anemia. Patient presenting to you with Ewing sarcoma and fever, which is not responding, usually have poorer prognosis. Leukocytosis, male patients, older age groups, elevated ESR, chemo resistance and relapse. These are the poor prognostic factors. Usually the MCQs will come around fever. So what will be the clinical presentation of a patient with Ewing sarcoma? Just like any other tumor, patient will present to you with a swelling, pain, pathological fracture, and incidental finding. Usually these patients show you presentation like an infection, and where there will be a swelling in the middle of the thigh because diaphyseal, or the middle of the leg because diaphyseal. It will be warm, red, local rise of temperature. Patient will also have high ESR and CRP. And sometimes if you put a needle to aspirate the contents of the swelling, the substances that come out look like a pus, because that is what is found in Ewing sarcoma, but it's not pus, right? It can confuse the clinician to make the diagnosis. Okay, so swelling in the middle of the thigh or leg, signs of inflammation, clinical and labs, all of them suggesting of inflammation. And usually there will always be an incidental history of trauma, because patients, because they're children, they don't remember what happened. Okay, and their parents also are not very observant because the swelling is increasing. So they will tell you that the child was playing and he fell down, and they will link that swelling with the history of trauma. That is the kind of story they will tell you. Now, what will be the X-ray findings of Ewing sarcoma? If you recall, the periosteal reaction, right? Sunray sunburst? No, sunray sunburst is seen in osteosarcoma. Here what will you see? Lamellated or onion peel appearance. Onion peel or lamellated appearance. What is this onion peel or lamellated appearance? It is periosteal reaction for a very rapidly growing aggressive malignant tumor. Okay, the periosteum is not given time to form around the swelling or the pathology because the tumor is so rapidly growing. Okay, can you look at this? This is the diaphysis, and these are the layered or the lamellated periosteal reaction. Very, very difficult diagnosis to make on X-ray. Just with the X-ray, it is very difficult diagnosis to make. So the investigation of choice, like any tumor, is biopsy. Now here is the interesting thing about Ewing sarcoma. It is a mesodermal tumor, because we know it arises from the endothelial lining of the bone marrow. Right, we read that. But the biopsy is ectodermal. The biopsy gives you a picture of a tumor that arises from the ectodermal. Right? Certain tumors that arise from ectoderm have a characteristic presentation. Have you heard of the term primitive neuroectodermal tumors? These neuroectodermal tumors, they arise from the neuroectoderm, right? So they will have a classical presentation of small round blue cells. You must have read this in pathology. So Ewing sarcoma also has small round blue cells, but we know that it arises from a mesodermal location, which is the endothelial lining of the bone marrow. Now, how does this happen? How can a neuroectodermal tumor arise from a mesodermal location? The answer is very simple. It happens because of a translocation. That is why this is the most common translocation seen in patients with Ewing sarcoma. Now, because of this translocation, neuroectodermal tissue has moved towards the mesodermal location. Okay? So, you will have small round blue cells with pseudo rosettes on biopsy, mimicking the neuroectodermal tumors. But how do you differentiate? You can differentiate it by doing a CD99 marker that will show you a MYC2 gene mutation. This is classical for Ewing sarcoma. Ewing sarcoma also has small round blue cell pseudo-rosettes that is seen in other neuroectodermal tumors. But because of MYC2 gene mutation, there is a CD99 positivity that will help us make the diagnosis. Okay, so these small round blue cells will be PAS positive and diastase digestible. So this word rosettes basically comes from something that looks like this. Okay, right. What else do you need to know? The other translocations that are seen in patients with Ewing sarcoma are these, but not very important. Trisomy 8 or 21 is also seen, but the most common translocation is 1122. Okay. For the sake of completion, what are the other primitive neuroectodermal tumors that can also show small round blue cells? Neuroblastoma, medulloblastoma, retinoblastoma. All of these will show that. But Ewing sarcoma will show CD99 positivity because of MYC2 gene mutation. Please remember that. Now, what about the treatment? You see, Ewing sarcoma is very, very radiosensitive. In fact, it melts with radiotherapy. But the problem is, this is a child. If you give radiotherapy, there are two problems. First, increased risk of radiation, meaning increased risk of secondary cancers. Second, the radiotherapy will destroy the surrounding tissue. That's why presently we are moving away from radiation therapy for the treatment of Ewing sarcoma. So the trend is towards surgical resection away from radiotherapy because of the morbidity associated with radiation and risk of secondary malignancy. So what do we do now? We give radiotherapy? No. We give chemotherapy? Yes. So we give chemotherapy and surgery as the form of treatment for Ewing sarcoma. So chemotherapy, limb salvage or resection, and again radiotherapy can be used if Ewing sarcoma is in places that cannot be accessed surgically. Then you can try it. Otherwise, presently we are moving away from radiotherapy for the treatment of Ewing sarcoma. But then there is a malignant tumor called as chordoma. Please pay attention. There is no N here. So no cartilaginous element. This is a chordoma which arises from the notochordal remnant cells. What are these notochordal remnant cells? Physalliferous cells. Where will they be located? In the location of the notochord embryologically. So embryologically, where is your notochord located? At the spine, base of the skull and sacrum. That is where it will arise from. So notochord has physalliferous cells which is left there as the patient grows. And these physalliferous cells transform into a chordoma tumor. That is what it is. That is all you need to remember about chordoma. Okay? Another rare malignant tumor is adamantinoma. It is a malignant tumor. It is a rare tumor. But please remember that it is unfortunately not a true bone tumor. It is an epithelial tumor. It is an epithelial tumor because of aberrant movement of epithelial cells from the skin to the bone. So that is why you will notice that adamantinoma occurs in bones that are subcutaneous, just under the skin. For example, tibia. So these epithelial tumors move into the bone and become bone tumors. What is so significant here? The significance here is that they also give you your classical soap bubble appearance, but only in the diaphysis. So this can be used to trick you on the exam. Soap bubble appearance, as we all know, occurs in the metaphysis or the epiphysis because of giant cell tumor. Epiphysis, it will go into the metaphysis because of giant cell tumor. But if it occurs in the diaphysis, then I want you to think of adamantinoma. Okay? Think of adamantinoma. That's it. Okay? Another epithelial tumor that occurs in the mandible is ameloblastoma. A lot of students get confused between ameloblastoma and adamantinoma. They are different. Adamantinoma occurs in the long bones. Ameloblastoma occurs in the mandible. Both of them are epithelial tumors. Finally, the last tumor that I want you to remember is synovial sarcoma. Also rare, not very common. And if you have to remember only one thing about synovial sarcoma, friends, is that it does not arise from the synovium. If you can remember this one point, you'll be able to answer 90% of the MCQs from synovial sarcoma, because this is one point that is tested again and again and again. Right? So synovial sarcoma does not arise from the synovium. It basically arises from the joint capsule, bursae and tendon. Usually occurs around the knee or the elbow. Translocation X18 which gives rise to the synovial sarcoma fusion gene. These are the two things that are asked on your exam. The treatment is surgery. So those are the few basic points that are tested again and again and again about malignant tumors. Please understand this one fact. The information that I have given you is basically a summary of the things that you need to know to answer MCQs. You're not becoming orthopedic oncologists here. You are becoming proficient to answer the MCQs. The aim here is to learn how to pick the diagnosis to mark on the exam. And once you know how to pick the diagnosis, then you will be able to answer based on the theory that you can read and that you have learnt over all the subjects across everywhere. Okay, that is what it is. The aim here is to basically learn how to differentiate or pick the keywords to mark the diagnosis. That is what is tested here. I have given you a table in the beginning, a few tables in the beginning to filter the information through. Majority of the bone tumor questions you will be able to answer with the help of those tables. That is more than enough. Because you will have the age, you'll have the location, you'll have the type of presentation, you'll have the type of radiological appearance, you'll have the type of histology on the biopsy. So you'll get most of the information to answer the MCQs. Sometimes you'll have to dig deeper, and for that I've given you the specific information for specific tumors. Now before I close, I'll give you the last few tables that are very, very important. Most of the simple MCQs will come from this, and you might make a mistake here. So let's start with what are the most commons in orthopedic oncology. So first question is, what is the most common malignant bone tumor? See, malignant bone tumor is unfortunately not a bone tumor. It is a metastasis. The most common malignant bone tumor is a metastasis, right? It's not a primary, it's a secondary. So most common malignant bone tumor is a metastasis. Now the question arises, where does this metastasis come from? To the bone, where does it come from? Most commonly comes from breast, followed by prostate, followed by lungs. Which means, if I ask you, what is the most common source of metastasis to the bone? In females, your answer will be breast. In males, your answer will be prostate. And if I don't mention the gender, what will you mark? Don't say lungs. Don't say lungs. Say breast only. Because if I don't say male or female, does that mean that they will neither have breast or lung, prostate? They'll only have lungs? Kya baat kar rahe? Right? So if I say males, you should say prostate. If I say females, you should say breast. If I don't mention the gender, you should say breast. Okay. In children, what is the most common source of this metastasis to the bone? It is neuroblastoma. Right. Now these metastases that go to the bone most commonly affects which bone? Spine. It affects spine. Which part of the spine? Lumbar vertebrae more than thoracic vertebrae. Okay. And when they affect the spine, how will they be visible on X-ray? We have a classical sign known as winking oval sign. What is this winking oval sign? If you take an AP view of the spine, what do you notice? You notice the pedicles. As the metastasis comes to the bone, it will destroy the pedicle. The pedicle will be destroyed. So it will look like the owl is winking. This is known as a winking oval sign, suggestive of destruction of the pedicle. Means there is a metastasis coming to the spine. Okay. So what is the most common malignant bone tumor? Metastasis. Where does it most commonly come from? Breast. Where does it most commonly go to? Lumbar vertebrae. Right. Now what is the presentation? What is the characteristic of this metastasis? The characteristics of the metastasis can be a bone forming metastasis, can be a bone resorbing metastasis, or can be a mixed metastasis. Sometimes they ask you, what are the purely bone forming or purely blastic metastasis? Purely blastic metastasis, they come from prostate, medulloblastoma, or carcinoids. Please remember this. Most commonly, prostate. Purely lytic metastasis means these metastases have destruction potential. Purely lytic metastasis come from renal cell carcinoma or follicular carcinoma of thyroid. Mixed metastasis usually come from breast. Okay? Ye ho gaya. So all of these are about metastasis. So we've discussed one MCQ. What is the most common malignant bone tumor? Metastasis. And after that we have discussed the story of metastasis. Another MCQ. Bone tumors that metastasize to other bones. So which are the bone tumors that metastasize to other bones? Matlab tumor was in the bone and it has metastasized to other bone. Ewing sarcoma and osteosarcoma. These are the tumors that metastasize to other bones. Bone to bone metastasis is seen in Ewing sarcoma. Okay? So what is the most common malignant bone tumor? We said metastasis and we have discussed all the story about it. Now if I ask you, what is the most common primary malignant bone tumor? So obviously when I say primary, I'm not talking about secondaries or mets. So the answer here is multiple myeloma followed by osteosarcoma, which again is very unfortunate. Multiple myeloma, we all know, is not a bone tumor. It's basically a blood tumor, right? It's a plasma cytoma. So if I ask you what is the most common primary non-hematological malignant bone tumor, then your answer will become osteosarcoma followed by chondrosarcoma. ठीक है? समझ आ गया? If I ask you what is the most common benign bone tumor, you know the answer is osteochondroma, but we know that it's not a true benign bone tumor. So the most common true benign bone tumor is osteoid osteoma. ठीक है? Also, if I would ask you what is the most common bone lesion, what will be your answer? Fibrous cortical defect. ठीक है? So please understand this. Whenever you start your revision for bone tumors, I want you to revise the tables that we discussed at the beginning and this most common in orthopedic oncology at the end of the discussion. And only then I want you to go to the middle of the topic of orthopedic oncology and explore the things in detail. Most of the times you'll be able to answer questions just with those tables and this last piece of information, and you're home free. Now let's practice a few MCQs and see how much we have understood about bone tumors. Try to stick to the tables that I've given you and you'll be able to answer. So let's look at the first question. Tumor that produces maximum bone matrix. Osteoid osteoma, chondrosarcoma, and chondroma none. So bone producing, basically, that's what it's asking. So which of the following is the bone producing tumor? Osteoid osteoma, right? Because chondrosarcoma and chondroma are cartilage producing. Next, which is not a metaphyseal tumor? Osteosarcoma, chondrosarcoma, giant cell tumor, aneurysmal bone cyst. I told you all the tumors are metaphyseal. So what are the two epiphyseal and two diaphyseal? Two epiphyseal are GCT and chondroblastoma. Two diaphyseal are Ewing's sarcoma and osteoid osteoma. So the answer here is giant cell tumor because it's epiphyseal. Before or after growth plate fusion? After growth plate fusion, because before it is chondroblastoma. Next, all are true regarding locations of the bone tumor except osteoclastoma and chondroblastoma are epiphyseal. Yes, true. Osteosarcoma, chondrosarcoma, and osteomyelitis and bone cyst are metaphyseal. Yes, true. Ewing's sarcoma and osteoid osteoma are metaphyseal? No. What are they? They are diaphyseal. So this is a false statement. Fibrous dysplasia is diaphyseal, but osteochondroma metaphyseal. Yes. So the answer here is C. This is the false statement. Simple. You just need to know the table of locations. Next. Which of the following is the most common mutation seen in Ewing's sarcoma? Translocation X18, translocation 1122, mutation of G5 alpha surface protein, missense mutation of EXT1 gene. Translocation 1122. That is why a neuroectodermal tumor rises at the mesodermal location. Small, round, blue cells with pseudorosettes, PAS positive, diastase, digestible. Yes. What else? MYC2 gene mutation leads to CD99 positivity. An 11-year-old boy presented with complaints of pain in the right arm near the shoulder. X-ray examination revealed a spansile lytic lesion in the upper third of the humerus. The most likely diagnosis is, so they're talking about humerus. They're talking about upper third, this part of the humor. It can be epiphyseal or metaphyseal. It's not mentioned it clearly. It's an 11-year-old boy. Can it be giant cell tumor? Obviously not, because giant cell tumor occurs after growth plate fusion. Can it be unicameral bone cyst? Yes, because it is usually metaphyseal in the proximal humerus. Can it be osteochondroma? They are not talking about a lesion that is growing in size. So let's not think about that. They are talking about an expansile lytic lesion, cystic lesion. Periosteal osteosarcoma, no. The answer here is unicameral bone cyst. Young child, cystic lesion in the bone, think of bone cyst. Next, Ramu was a 16-year-old boy present with pain in the arm. On X-ray, his upper end of the humerus demonstrates an expansile lesion in the metaphysis. So again, upper end of humerus, expansile lesion in the metaphysis. Clearly, they are telling you metaphysis. With breach of the overlying cortex, what is the most likely diagnosis? Is it aneurysmal, unicameral, or chondroblastoma or osteoclastoma? It cannot be osteoclastoma because it occurs after growth plate fusion. It cannot be chondroblastoma because it is epiphyseal. What are you left with? Simple or aneurysmal bone cyst? What will you go for? Slightly older person with a breach in the overlying cortex? I will go with aneurysmal bone cyst. Yes, it can be simple bone cyst also, but slightly older person and breach in the cortex suggesting it's more aggressive. I will go with aneurysmal bone cyst. So what are you using? You're using location in the bone, epi, meta, diaphysis. You're looking at the age of the patient and that's it. How is it cystic, lytic, bone forming? Based on that, you are making the diagnosis. So please practice those tables that I've given you. All are true about aneurysmal bone cyst except eccentric. Yes. Expansile and lytic? Yes. Treated with simple curettage? Aneurysmal bone cyst, is it treated with simple curettage? Please tell me. No. It's treated with extended curettage. You curate it and you extend the curettage with liquid nitrogen, phenol or bone cement. Right. Which other condition do you use extended curettage for? Giant cell tumor. Giant cell tumor. So this is a false statement. Metaphyseal of the long bones, yes. Aneurysmal bone cyst and simple bone cyst, they're all metaphyseal. The answer here is C. Next, a 12-year-old boy presented with symmetric expansile cystic lesion in the proximal humerus. So proximal humerus, there is a cystic lesion, symmetrical and expansile. All of the following can be done for his treatment except. So I'm thinking they're talking about simple bone cyst. Okay, because they are giving you the word symmetric. Curettage can be done? Yes. Intralesional steroids can be given? Yes. Intralesional sclerosing agents can be given? Yes. Radiotherapy? Oh, that will be a little too aggressive for a simple bone cyst, right? So the answer here is radiotherapy. There is no need to be very aggressive, right? Excision, curettage, intralesional steroids, intralesional sclerosant therapy or conservative management. That should suffice for simple bone cyst. Paget's disease after 10 years of presentation can develop into osteosarcoma, fibrous cortical defect, osteodysteoma or ankylosing spondylitis. Paget's disease, long-term, increased risk of osteosarcoma. Which primary or secondary osteosarcoma? The answer is secondary osteosarcoma. I've told you this. It is the most common cause of secondary osteosarcoma. The other cause is fibrous dysplasia and exposure to radiation. An 8-year-old child has fever with pain and swelling in the mid-thigh. Right? Mid-thigh means epimetadia. Dia. X-ray reveals a lamellated appearance and Codman's triangle. So lamellated appearance is also there, as well as Codman's triangle is also there. Histopathologically shows a small round cell tumor positive for MYC2 gene. What is the diagnosis? Without even looking at the options, you can make the diagnosis. What is the diagnosis? Ewing sarcoma. Osteosarcoma, no. Ewing sarcoma, yes. Chondroblastoma, no. Multiple myeloma, no. Why? First of all, osteosarcoma is metaphyseal. Chondroblastoma is epiphyseal. So the here answer is Ewing sarcoma is diaphyseal, MYC2 gene positivity and small round blue cells with pseudo rossettes. Okay? Answer is Ewing sarcoma. Got it? A 7-year-old boy with a history of trauma 2 months back presents with fever and acute pain over the thigh. So again thigh. X-ray femoral shaft shows lesions with multiple laminated periosteal reaction. What is the next line of management? So they have given you the diagnosis, which we all know is Ewing sarcoma, and they are asking the next step in management. They've only gotten X-ray done. CRP measurement, core biopsy, technetium-99 scan or MRI. What is the next step? The best step would be biopsy, but the next step would be to get an MRI. Why? You want to see the extent of the spread of the disease. You want to see the extent. So you'll go for MRI. Best investigation would be biopsy. A 10-year-old boy presents with cortex-based radiolucent lesion surrounded by a reactive sclerotic margin. Okay, so there is a cortex-based lesion which is radiolucent surrounded by a dense sclerotic margin. In the middle of the shaft of tibia means diaphysis. The most likely diagnosis is, so young boy, cortical lesion, lucent nidus, sclerotic rim. What do you think is the diagnosis? Without looking at the options. Answer is osteoid osteoma. Without looking at the options, I can say that it's osteoid osteoma. Right? That's how powerful it is. A 14-year-old boy presented with painful swelling over the left shoulder. Okay? Left shoulder, there is a painful swelling. Where exactly we don't know. Radiograph of the shoulder showed an osteolytic area with stippled calcification. Lysis with calcification. So must be something to do with cartilage. Over the proximal humor epiphysis. So epiphyseal lesion in a child, lucency with stippled calcification. What is the diagnosis? We are already coming towards the diagnosis. Biopsy of the lesion revealed a immature fibrous matrix with scattered giant cells. Which of the following is the most likely diagnosis? Giant cell tumor, chondroblastoma, osteosarcoma, chondromyxoid fibroma. Since it's epiphyseal, it cannot be osteosarcoma, it cannot be chondromyxoid fibroma. Both of them are metaphyseal. Now we are confused between giant cell tumor and chondroblastoma. How will you help? What will help? Young patient. So growth plate must be open. So must be chondroblastoma. But sir, there are scattered giant cells. Na? If you recall giant cell tumor variants, you will remember that it also had chondroblastoma in the list. Chondroblastomas also have giant cells. Since it's a child, We are going with chondroblastoma as the answer. Good question, isn't it? But you're smarter. You're smarter. Next, a 45-year-old male presented with an expansile lesion in the center of the femoral metaphysis. Okay? Yeah, femoral metaphysis. In the center of the metaphysis, there is an expansile lesion. On X-ray, the lesion shows endosteal scalloping and punctate calcification. What is the most likely diagnosis? 45-year-old male. Can it be osteosarcoma? Osteosarcoma is a bone forming, so it must be osteoblastic, dense, sclerotic. Chondrosarcoma, possibly, because lytic with calcification must be cartilaginous. Tumor, simple bone cyst, no. Usually occurs in children. It's a simple centric cyst. There is no calcification there. Fibrous dysplasia, no. Fibrous dysplasia also no, because there is a fibrous replacement of the bone tissue. So no calcification there. The answer here is chondrosarcoma. And the word punctate calcification, endosteal scalloping, popcorn calcification, ring sign, arc sign, all of are suggestive of chondroblastic or chondrocytes ka tumor. Commonest malignant tumor of the skeletal system is, what is the most common malignant bone tumor? Answer is metastasis. Right? The answer is metastasis. Metastasis is usually not found in femur, humerus, fibula, spine. In which bone will the metastasis not be seen in? Answer is fibula. You see, metastasis usually does not occur in small bones. It doesn't occur in the small bones of the hand and feet. It also doesn't occur in the fibula. Usually occurs where? In the spine. Which spine? Lumbar more than thoracic vertebrae. Right. All of the following statements about synovial sarcoma, synovial cell sarcoma are true except originate from the synovial lining. I've told you this. If you can remember only one thing about synovial sarcoma, it is that it does not arise from the synovial cells. Right? So it does not originate from the synovial lining. Right? So it is a false statement. Occurs more in extra-articular sites? Yes, true. Usually seen in patients lesser than 50 years? True. Knee and foot are common sites involved? Yes, true. So the answer here is A. Originate from the synovial lining. A 10-year-old male child presents with pain around the left knee joint. So left knee joint, pain somewhere around here. On X-ray, there is a lesion at the distal femur. So there is a lesion at the distal femur. Following is the clinical image. What is the most probable diagnosis? So this is the clinical image. Is it giant cell tumor? It cannot be 10-year-old child. So it cannot be. Osteosarcoma? Possibly. Osteoblastoma? Is it so aggressive? Osteoblastoma usually occurs in the spine and it's not so aggressive. Chondrosarcoma occurs in older population. So the answer here is osteosarcoma, because you can clearly see that there is this sunrise sunburst appearance and there is this Codman's triangle. This is your osteosarcoma. Okay? Clear? Next. Which statement is incorrect about the pathology shown in the image? So now you have to make the diagnosis. Only then you will be able to answer this question. Otherwise, no. How will you make the diagnosis? Read the X-ray. Femur, tibia, fibula, growth plate, not there much in mature patient. Lesion is in the epiphysis, moving into the metaphysis, multiloculated, expansile lesion. What is it? Is it a GCT or an ABC? It is a GCT. Right. Based on this, you will be able to answer the question. So looking for the incorrect statement. Tumor has distinct margins. Yes. Is eccentric. Yes. Arises from the epiphysis. Yes. Chemotherapy is the treatment of choice. No. What is the treatment of choice for giant cell tumor? Tell me, you know this. Extended kerata. So the answer here is D. Are you understanding how making the diagnosis is critical to answer the MCQ? Without making the diagnosis, you cannot do anything. And I have taught you how to make the diagnosis. That is the most powerful thing that you can pick up from this lecture. Make the right diagnosis. Next. Let's practice a few more questions here. So these are the spotters that I want you to remember. Again, see, knee, growth plate is fused, lesion in the epi moving in the meta. This is GCT. Again, lesion in the epi moving in the meta. Growth plate fused, GCT. Growth plate fused, lesion in the epi moving to the meta. This is giant cell tumor. And this image, my friends, oh my God. I cannot stress how important this slide is. Work your way into it and then you will be able to answer a lot of MCQs on the exam. Look at this lesion. X-ray of the distal end of the radius. Growth plate is fused. Lesion in the epi moving to the meta of the distal end of the radius. This is your giant cell tumor. Okay, hammer this into your head. This image. X-ray of the knee. Growth plate is open. Must be a child. Epi is normal. Lesion is in the meta. Multiloculated, multiseptate expansile lesion. This is your aneurysmal bone cyst. Okay, friends, very, very important slide for your exam. What about this? Proximal humerus, growth plate open, lesion in the meta, that is a single solitary centric cyst. This is your simple bone cyst. What about this? Lesion in the meta, growth plate open, epiphysis normal, multiloculated, multisepted. This is your aneurysmal bone cyst. Okay, confident now, right? I'm sure you are. Next, the treatment of the condition given below is, so this is the condition, they want to know the treatment. Make the diagnosis, without which you will be unable to answer the MCQ. So look at this, X-ray of the knee, lesion in the distal femur, growth plate fused, lesion in the epi, moving into the meta. The answer is giant cell tumor. Now based on this, you have to make the answer. The treatment of this condition is extended curettage, yes, but with allograft. Bone biopsy, that's not the treatment. Curettage, no. Extended curettage with autograft. Answer is extended curettage with autograft. Autograft is basically bone graft from the patient. That is always better than allograft. Okay. A 30-year-old male patient presented with complaints of gradually progressive swelling around his wrist joint for 3 months. So there is a swelling around the wrist for 3 months. Given below is the image of the swelling and the X-ray film. What is the most likely diagnosis? Again, the diagnosis has to be made here with the help of the image provided. And then you will be able to think about anything else that they want to ask. But lucky for you now, they're only asking the diagnosis. So look at this X-ray of the wrist. Lesion is in the distal of the radius. Starting in the epi, moving to the meta. Growth plate is fused because the age is 30 years. What is it, friends? What is it? At least tell me what is it. It is giant cell tumor, or also known as osteoclastoma. And can you tell me the treatment of osteoclastoma? Extended curettage. Okay, so one last question. Okay, recent INI set question. Match the following with the best mode of management. Osteosarcoma, simple bone cyst, giant cell tumor, osteodosteoma. These are given. Treatments are wide excision, curettage, radiofrequency ablation, intralesional steroids. What will you give for what? Intralesional steroid you will use for, come on, simple bone cyst. Very good. Giant cell tumor, extended curettage. So extended curettage is not there. We'll go with curettage. Osteodosteoma, radiofrequency ablation will suffice, or aspirin would suffice. Osteosarcoma, wide excision or limb ablation surgery. So A is 1, B is 4. A is 1, B is 4, C is 2, and D is 3. So the correct answer, my dear friends, is B. Okay? Are you confident now? Practice more MCQs. Read the X-ray step by step and remember the tables that I've given you. And trust me, if you do that, majority of the MCQs in bone tumors you will be able to answer. And history has proven this. It has worked for me. It has worked for thousands of students that I've taught, and it will work for you. Trust it, practice it, and revise it. I'm sure you'll find that the bone tumors is not so hard anymore.